Dr. Narayan, thank you so much for joining us. And again, also, I wanted to continue a few more questions, actually. Specifically, one thing I really didn't touch upon last time was something that you have actually mentioned a few times, and you've given lectures about this, is the role of the famines. In terms of the predisposition of South Asians towards diabetes. One of the papers that you recently published, I think with Dr. K in Nature Endocrinology Reviews, you specifically mentioned the Bengal famine as one of the possible reasons through epigenetic effects that there's reduced beta cell proliferation and insulin resistance in South Asians, akin to what the Chinese experienced during their Great Famine.
Yep.
And I was, really curious if you could elaborate on that. And I think in one of your other papers, you also mentioned how the colonial famines, probably the colonial policy, exacerbated the situation for South Asians.
Yep. Okay, good. So let me step back and give some background to this. When you look at the over time, there's a group in Cambridge University, physical anthropology group, who have been studying a lot of, the physical anthropology of the South Asian subcontinent. And what they've established quite strongly, it's long-term data, but in the Mesolithic period, you're talking 10,000 years ago.
Yep.
When they compared 6 Western European populations, 3 Eastern European populations, and 3 South Asian populations, and there's 2 South Asian populations, one in the Gangetic Valley, the other in the Indus Valley. At that time, the tallest people in the world were the Indian subcontinent people. This was 10,000 years ago.
Which is really very amazing.
Yeah, absolutely. And the reason height is so important is the determinants of heights are twofold. Number one, genetics, but the modifiable influence is maternal child nutrition. Okay? So something 10,000 years ago, the people of the Indian subcontinent, the populations were lower everywhere, were the tallest in the world, and therefore by inference, most nutritionally nourished at that time.
Yeah.
Then Barry Popkin and others have tried to reconstruct what has happened to the heights of world populations over time. And what we see, what they've shown, is there has been a steady decline in the average height of South Asian population over the past 10,000 years. I mean, during various periods of time. So that is there's a strong reason that that trend of nutrition not keeping up with the population size, the Malthusian effect had been ongoing for a long time. But more recently, it is true, if there was one thing very predictable under British colonization of India during those 200 years, it was the predictability of famines. Okay, food insecurity became almost a regular feature. I mean, the Bengal famine is the extreme example, and even today, there is not an accurate count of how many people died during the Bengal famine. It might be 3-4 million. People are, coming up with various estimates. But clearly, there were frequent famines across India during the 200-year colonial period, and a lot of that had to do with British policy.
In fact, I came across a paper that between 1800 and 1899, there were 24 major famines. More than in any other period in recorded history.
Yeah, absolutely.
This is a paper by Dr. Sarab.
Yeah. So when you're talking a 200-year history, colonization, that's about 8 or 9 generations or 10 generations. So during that time, there was the frequency of famines was considerable. Okay, and so that was clearly happening. So that's the context. And the other thing to clearly remember is a lot of this was to do with British colonial policy. They were not creating famines for the sake of creating famines, but that was their economic policy. That was the loot was the issue. They were less concerned about the population and more concerned about their empire. And indeed, when you look at the economic history of the world, in 1750, the per capita income in India and the per capita income in Britain was roughly similar. I mean, Britain was slightly higher, industrialization had just started, but they were roughly similar. But by the time the British left in 1947, 1950, in the 200 year,
Mm-hmm.
adjusted for today's inflation, the British economy grew something like 7 times. Per capita income grew 7 times, but the
Yeah.
Indian per capita income remained almost flat throughout that period.
Yep.
And it's often historians in immediate post-colonial India argued that that is because of India's population growth.
Yeah.
So in one of my papers, I took a look at the change in population during the same period, 1750 to 1950. The British population grew 3 times faster than the population of India.
Oh, that's so fascinating. That's so interesting.
So what that means is that the total economy of Britain grew 21 times and their per
Wow.
capita income grew 7 times. So
Yeah.
there was famines and there was also, relative poverty and extreme
Mhm.
poverty. So in 1947, when modern India was created, it was something like 575 kingdoms coming together.
Mhm.
The poverty level in India was 92%,
Ah,
okay? And the literacy level was 10%. So
yeah.
India was in a very bad shape at that time. So
Mhm.
that's the background.
In fact, it was actually I've heard quotes. Dr. Manmohan, Prime Minister, not Prime, it was yeah, Prime Minister Manmohan Singh. He came to England and he mentioned that you left. It was like India was actually the poorest and the most illiterate country in the world at that time.
Absolutely. And in 1750, it was about the most well-governed, the richest countries in the world. And, India, if you look at the last 2,000 years of world history, for
Mhm.
1,800 years, India has been the largest or the second largest economy of the world. It has always been
Mhm.
that way. Yes,
Yeah.
population size mattered, but all that set aside. Now, the context of today's discussion.
Yes.
So we have this historical increasing malnutrition, uh, accelerated during the colonial period because of famines and also because of food policy,
Mhm.
loss of economic development, etc.
Yeah.
You're talking about life expectancy in 1950 of 30 years in India, okay?
Yep. Exactly.
So why is this relevant? Because when you look at the connection between undernutrition or famines and later cardiometabolic risk, particularly risk for diabetes, cardiovascular disease, there are data like you mentioned from the Chinese famine, which was created in, during the time of Mao Zedong. Again, similar policies.
Mhm.
It was ideas to suppress the peasants. So data from that study from that time clearly suggests that people born during the famine have higher risk of diabetes,
Mhm.
and cardiometabolic disease. There
Yes.
is
Yes.
another study in Netherlands, the Dutch famine study, showing exactly the
The
same.
winter hunger famine, perhaps. Yeah.
Yeah, that's right, the Dutch famine study. So
Mhm.
there is considerable data from various famine studies connecting, famines to later development of diabetes. And
Mhm.
more recently, there are what we call birth cohort studies. Okay, the classic ones, the New Delhi birth cohort has followed children from birth to adulthood.
Huh.
And similarly, there is a cohort in Mysore called the Parthinan cohort, which has
Yeah.
followed children from birth to adulthood.
Mhm.
There have been other, birth cohort studies. So all these birth cohort studies show that children that are born low birth weight or stunted, in other words, they
Oh,
are malnourished because of maternal child malnutrition, have a higher risk of glucose intolerance and diabetes in adulthood and also cardiovascular disease. So
mm.
that is the other connection. And there's also, the Harvard studies have also examined the relationship between birth weight and cardiometabolic disease, and they found similar findings that low birth
Yeah.
weight and stunted people. And there was actually more recently a very definitive meta-analysis on the topic, which convincingly shows that low birth weight raises the odds of diabetes in adulthood by something like
Oh,
twofold or something like that, twofold, I think.
yeah.
And what was really interesting when I read that paper very carefully, that it raised the risk of diabetes, but only raised the risk of high fasting glucose.
Ah,
not the risk of high 2R glucose or high hemoglobin A1C.
wow.
And
Just
why
like
is
you would
that?
see in South Asians.
Yeah. And why is that important? It's important because fasting glucose is a measure of two things. It's a measure of poor beta cell function, and
Hmm.
it's a measure of hepatic insulin resistance.
Ah,
So what this suggests is that the low birth weight, then diabetes occurring in low birth weight, in low BMI people who carry the thinness through life, and still have a higher risk of diabetes because of the low birth weight, is really a variety of poor insulin secretion to start with. So the
ah,
pancreases are compromised, and on
ah,
top of that, small amounts of fat in the liver accelerates diabetes. So I think the connection between maternal child nutrition and diabetes later in life is extremely strong at the moment.
ah.
Exactly why that is the case, where the trauma is occurring, what's causing it, that we don't know. But again, I can share with you that just based on 5 pancreases that we have studied in normal people without diabetes in Hyderabad and
Yeah,
compared it to similar pancreases in Europeans in the US, we find that the pancreases in Indian populations are compromised. Not everybody in India, but a sizable
yeah.
proportion of people. So I think the history of undernourishment, accelerated by the periodic famines, poor
Uh-huh.
economic policy under the British for the Indian population, all together conspired to create generations of Indians who have had this disadvantage in terms of
Yeah.
metabolic disadvantage. And now with modernization, this problem is surfacing very rapidly. I think that is
Ah,
clearly what is happening.
right.
So, and I think this finding may not be unique to India. I think it might be true for the African continent. It might be true to
Hmm.
other parts of the world, like I said, the Chinese famine. So it
Yeah.
might be a little more generalizable information. So I think definitely in the case of India, one of the successes of India during the Green Revolution was that India was able to feed her masses, her people.
Yep.
But one of the paradoxes since 1992, in spite of massive economic growth in India, the proportion of children who remain stunted and low birth weight has remained somewhat constant. So, yes,
Yeah.
nourishment is improving, there is obesity happening in children also in India, but the proportion undernourished is also remaining static. So, we have to solve both the problems, the
Yeah.
undernourishment in maternal child undernourishment, and also the overnourishment or the malnutrition,
Hmm.
obesity in older children. I think both have to be solved.
Yeah. Do you think this genetic effect, or there is obviously there may be a genetic effect you're talking about or alluding to, is that something that do we have a sense of how long that may be persistent in terms of passing it from each generation to the next?
Yeah, it's a very good question. But I think I think when you understand, when you look at it as a biological phenomenon, it may possibly have been an adaptation issue.
Mm,
So the bodies may have adapted to this kind of thing. So maybe is it a fixed gene effect or is it an epigenetic effect,
yeah.
which is transient, but still we
Hmm.
don't know.
We don't know. Yeah.
Yeah, but there are two clues here. One is pessimistic. Okay, so in Pune, there is a paper from Pune, the laboratory in Pune, in a very nice journal, where they examined mice. So what had happened? For some reason, the mice, it was Dr. Yajnik who published this. The
Uh-huh.
mice, they forgot to feed the mice for a few days in the lab or something, like
Yeah.
something went wrong. And they
Okay.
noticed when they sacrificed the mice had started developing metabolic, signs. So then they decided to starve the mice through low carbohydrate, low energy, poor quality diet for
Uh-huh.
I think 21 generations or 22 generations, I can't remember. And the
Yeah.
metabolic consequences got progressively worse. And then they put the mice for 2 generations of rescue diet, which is high quality diet,
Hmm.
and things didn't change. In the mice, thing didn't change. Okay, so that is a little bit of a pessimistic thing, suggesting that these changes
Ah.
maybe less plastic than you think, might last longer. But
Yeah.
on the other hand, there is a study from Guatemala and a
Hmm.
couple of other places which show that early supplementation, protein, calorie supplementation, improvement of childhood malnutrition can, by early adulthood, have some positive effects. So I think, if the other thing that makes me feel confident is when you compare the rates of diabetes in urban India with the rates of diabetes in Indian Americans in the US, in Chicago and California. The Indian Americans in US seem to have lower rates of diabetes than Indians in Chennai, suggesting that within a generation of good nutrition, things could start improving. And that's also true. There was recently a paper published just last week on cardiovascular disease mortality in Asian Indians. Generally, when you compare the foreign-born Asian Indians, their risk is about twice the risk of cardiovascular heart attacks than native-born Asian Indians in the US. So suggesting that changes in environment, changes in policy might start reversing this phenomenon.
Okay, well, that's excellent. I was going to ask you another question. Is there any evidence about for South Asians that there's been any evidence of epigenetic changes that, like they've shown, I think, in some populations like the Chinese?
Yeah, good question. I mean, overall, when you look at the fixed genes, the major genes that are known for diabetes, I think it's fair to say that those major genes are so far, I think 18% of the world's diabetes is explained by the known genes. I think, and those genes seem to be quite common across all global populations, okay? There might be some changes, some differences in allele frequency, etc. But the major genes tend to be fairly replicable at the moment, and having said that, there's a lot that is unknown. So when you take genes from European studies and try to replicate them in Asian populations, only about 22% of them are replicable. That's the other problem. But in terms of the epigenetic changes, the best study there is in this area is in British Indians compared to white British people. So when they looked at them, when they compared them, there were 5 genes that were associated with diabetes risk in both the populations. So the genes were similar, but when they looked at the epigenetics or the methylation on the genes, there was a higher level of methylation in the South Asians or in the Indian British people, suggesting that although the genes might be similar, the epigenetic phenomenon, which is the gene's expression or the change to its environment, might be more in South Asians. But this is exactly the kind of study we need. We need more epigenetic studies in very young children. I think these epigenetic
and methylation, just so I understand, so DNA methylation is a marker for epigenetic change.
Yeah, there are several markers. Yeah, DNA methylation is one common thing. There is changes in histone, mRNA. There are various other techniques.
And by the way, for our audience, epigenetic change refers to changes that occur in response to the environment.
The changes that occur to the genes don't change, but the changes that occur to the genes in response to the environment or to any
such as a famine.
Famine is one example.
As an
or physical activity. Physical activity can change, epigenetics. Obesity can change epigenetics. Processed foods might change epigenetics. So these are very interesting areas. Yeah.
Okay, great. Well, that's excellent. And I know you've achieved so much in your field so far. What would you hope to accomplish with this research?
I mean, firstly, it's very kind of you to say. I feel privileged that I've had a good career and have been able to contribute. I mean, the difficulty with science and with research is it's difficult to predict the future. So I think when you ask that question, I think I do science for 2 reasons. The first reason is the pure curiosity of uncovering the truth. Okay, we need to understand what is the truth. So we may all have our opinions as to why South Asians are at high risk or etc. So we need to understand that clearly. I think that's the primary focus of a good scientist. And in the lifetime of a scientist, we often prove ourselves wrong a few times. That's something that happens. So I'd like to maintain that level of rigor in science. And increasingly, thanks to the funding that we are getting to do work with South Asians in India and in the US, in addition to other populations, I'm hoping that we will be able to alter the equation that although 23% of the world's population is South Asians, less than 1% of research comes from South Asians. So I'd like to alter that
Yeah.
and improve the understanding of the
Mhm.
causes of diabetes in South Asian populations, and more than understanding, also improve the ways of preventing diabetes in
Yeah.
South Asians, ways of better treating diabetes in South Asians, etc. So that's one agenda. The other thing is a more practical, kind of orientation, where you want to do some implementation of the good research that is available. So, clearly, I've been involved with diabetes prevention studies that shows that in people with impaired glucose tolerance, which is a type of prediabetes, with lifestyle intervention, you can prevent progression to diabetes. So, getting that implemented large scale is very important to me. And
Yeah.
similarly, in the United States, we have done various studies and the work from CDC that by improving quality of care for people with diabetes, we have shown you can decrease mortality in people in people with
Wow.
diabetes. You can reduce the risk of complications in people with diabetes, and we have taken the same ideas and replicated those trials in India and Pakistan, showing it's feasible to do it there. So I'd
That's
like to
so
see
that's so optimistic. That's
yeah,
great.
so I'd like to see, in fact, so I'd like to see a better organized implementation of diabetes prevention and diabetes improvement of diabetes quality of care uh, for the scale in scale. So
Yeah.
if there are 120 million, 70, 80 million people with diabetes, I'd like them all to benefit. If there are 200 million people of diabetes with pre-diabetes in India, I would like all of them to benefit. So I think, so taking that, which is what I would call implementation science. So I think these are the two areas. One is the curiosity driven, let's understand the root causes where we might be in for some surprises. It's
Yeah.
very possible in 10 years my hypothesis could be wrong or right. I mean, I want to remain, humble about it. But
Yeah.
what I think we can do is through organized effort, through policy, we can definitely deliver better quality prevention, better quality care, better quality treatment for masses of people with diabetes at low cost. And I think those are the two things I'd like to see happening.
Wow. That's such good news for South Asians.
Thank you.
Well, that's wonderful. And thank you so much, Dr. Narayan, again, for such a fascinating interview.
Yeah.
And I want to, again, thank everyone for joining in and listening. This is Dr. Mubin Syed, your Desidoc, and this is part of our Expert Spotlight series. And thanks again for
Yeah.
your time, Dr. Narayan.
Thank you, Mubin. I think thank you for doing this. I mean, this is
Oh, our
a
pleasure.
tremendous service that you're doing to the community, and because good science needs to get communicated to
Yes.
people, and I think
Mhm.
that's so. I love the idea that you're creating that interface, and thank you for doing this.
Oh, thank you so much for
Thank you.
saying that.
Bye bye. Bye bye.
Bye.